Welcome back, everybody. We're going to continue in the solid tumor vein with a talk from Sekkath Veedu from the University of Kentucky on the immunotherapy of prostate cancer, continuing in that solid tumor vein.
All right, I'm one of those speakers where I always have to adjust the mic because standing at 5'4", but especially when Dr. Emmons is also talking. So my name is Janish Sekkath Veedu. I'm an assistant professor at University of Kentucky. With the Division of Medical Oncology. I do GU, GI, and a little bit of lung as well. I would like to thank Dr. Emmons for this opportunity and Dr. Anthony, my chief, for thinking of me when this opportunity came over. A lot of people might be thinking, what is there in immunotherapy in prostate cancer? What am I going to talk about 25 minutes? But there is something which we can always talk about in the prostate cancer world and immunotherapy. Here are my disclosures. I will not be discussing any off-label use. I'll be definitely mentioning clinical trials that I have used drugs which are not approved, and no other financial conflicts. Here are the objectives of my talk. We'll briefly review the current treatment paradigm of metastatic castration-resistant prostate cancer. We won't be talking a lot about metastatic castration-sensitive or non-metastatic castration-sensitive prostate cancer. We'll be discussing relevant and promising clinical trials and why some of them worked, why some of them didn't work. And lastly, I would like to spend some time about discussing about emerging therapies. This is the overview of prostate cancer, very common cancer, about 313,000 new cases in 2025, which is about 15.4% of all cancers. Mortality is 35,000 deaths, but the mortality rate is not as high as the number of new cases. Thanks to early detection, maybe, and higher chance of being found in early stages, stage 1, 2, the survival rate is 97.9% overall. This is very similar to breast cancer, or maybe even better than breast cancer, 5-year overall survival. Prostate cancer in Kentucky. The top left cartoon you see is the incidence of prostate cancer rate in Kentucky. Lexington, Fayette County, and Jefferson County has a higher incidence, and mortality rate does not follow a specific pattern. That's the top right graph. If you divide Kentucky into Appalachia and non-Appalachia, there is no increased incidence of prostate cancer in Appalachia compared to lung cancers, probably because lung cancers are driven by smoking, and the mortality rate of prostate cancer in Appalachia is actually less than non-Appalachia. This data is a little bit old and probably 3-4 years old. I don't expect this to change in the next upcoming publications. So this slide, I'll spend a little time on this. I'll say what are the most common drugs that is used in metastatic castration-resistant prostate cancer. We know it is docetaxel continues to be the mainstay of treatment, especially in the castrate-resistant metastatic world, and also in the high-volume metastatic castration-sensitive prostate cancer world. The newer hormonal agents continues to play a major role, which includes enzalutamide and abiraterone mostly in the CRPC world, and in the castration-sensitive world, we have the darolutamide and apalutamide. And we also have PARP inhibitors that has come out in the past 3 years, which has been proven in combination with hormonal agents, which includes niraparib and olaparib with abiraterone, and talopro with for homozygous recombinant deficiency patients. One thing I would like to highlight is pembrolizumab, Keytruda has been approved, but this is only for patients with high TMB, deficient MMR, and we also have dostarlimab, which also has a tissue-agnostic approval for any patient who has deficient MMR. You can use them. I'll be talking about one of these drugs and one other drug in subsequent slides. So when I got a call from Dr. Anthony saying, hey, would you like to talk about immunotherapy in prostate cancer? This was right about the time, maybe a week after I read this study, and I'm like, okay, yeah, this is a perfect time to talk about this study in the upcoming talk. So this is Keynote 921, which was published on March 5th, 2025, published by Dr. Petrulak in JCO. He's from Yale, has been one of the pioneers in prostate cancer research, especially the docetaxel used in early 2004. So this trial included patients who have been heavily treated with newer hormonal agents that includes abiraterone and enzalutamide, metastatic castration-resistant patients. They had two primary endpoints. One of them was radiographic progression-free survival, and the second one was overall survival. Safety was a secondary endpoint. They had other endpoints as well, which include time to PSA decrease, 50% reduction in PSA, as well as time to the next treatment. Pretty large study, multi-center, international, 224. They had 1,030 patients enrolled, 515 in each arms, well balanced in terms of characteristics, 100% men, and only 2.5% of African Americans. Why I would like to say that is, like in most other clinical trials, we have an inadequate representation of the minority communities. But with regards to other characteristics, including what they received before, the pattern of metastasis, both arms were very similar. What was the rationale behind Keynote 921? There were some phase 1, phase 2 trials which showed some promising activity. They were not fantastic, but they were enough to justify a phase 3 clinical trial. Dr. Petrulak himself did a phase 1A study of atezolizumab. This was a small study of 35 patients in patients who were previously heavily treated with chemotherapy, including docetaxel. There was 8.6% percentage of patients who had a 50% PSA reduction, and median overall survival was 14.7 months. Dr. Karim Fizazi from France, he did a phase 2 study with Nivo. This was patients who did not receive docetaxel before, so he combined nivolumab with docetaxel. This had a higher response rate of 40%, and had a radiographic progression-free survival of 9 months. There were 2 keynote studies prior to 921. One of them was phase 2. This is a keynote 199. There's the slide does mention it's pembro with docetaxel. Actually, I have to correct that. It's actually pembro monotherapy. My apologies for that. It had 3 different cohorts, and they divided the cohort based on PD-L1 positive, PD-L1 negative, and bony metastasis. The patients with bony metastasis actually had the best overall response rate. The other 2 groups had modest overall response rates. Immediately prior to Keynote 921 was the phase 1b2 Keynote 365, where they studied pembro with docetaxel and did see very similar response rate of 30-34% in the PSA reduction with overall response rate of 23%. And this was the one which led to the phase 3 Keynote 921. So in summary, all of these phase 1, phase 2 studies were promising, did not show a lot of promise, but was enough to justify Keynote 921. So then what did it show? Nothing. Unfortunately, nothing. It was a big disappointment. Some people say this could be the last of the combination immunotherapy trials with docetaxel. Hopefully not. But I do think there are some important things which we can take from this trial for future drug development and future trials, and why didn't we succeed in this combination. So overall, there was some signals which might be useful for future trials. The median overall survival in all patients was around 19.6 months versus 19 months in the placebo arm. This did not differ based on PD-L1 positivity. It didn't matter because in the PD-L1 positive group, the overall survival was 19.8 months, which was very similar to overall population. Interestingly, in the PD-L1 positive population, in the placebo group, they had a little bit of less response by median survival was less 5 months. This is probably because PD-L1 expression in prostate cancer might be a marker of aggressive disease, but none of these was less than 95% confidence interval of the hazard ratio. Basically, they did show some signals which were favored treating pembro docetaxel combination, but there was no statistical significance. Same with overall survival, no difference. What is important is it did not matter what your PD-L1 expression was. It did not matter what your metastatic pattern was. It did not matter whether you were treated with abiraterone or enzalutamide. And it did not matter what your prehistory was. Overall survival, it was consistent with previous studies, and including Keynote 199 and 365, and other studies which included Checkmate. There was a lot of patients who crossed over to either one of the study drugs or subsequent treatments. around 40% of these patients received cabazitaxel. So a lot of the benefit from in overall survival in these patients could be from because they progressed to cabazitaxel. More than 90% of these patients had discontinued the study. A significant number of them had died, and a lot of them received cabazitaxel. So the highlights of this study, I'll start with the bottommost point. It was a failure. As I mentioned, it was mostly cabazitaxel. It did set a benchmark for a combination of pembrolizumab and docetaxel of 19 months, which is a new standard in a phase 3 clinical trial. The data was very similar to trials with Nivo. There was no increase in toxicity except for pneumonitis. There was a slightly higher chance of pneumonitis, but like the previous phase 1, phase 2 studies, it did not show any increased signal of toxicity. Now, why do immunotherapy fail in prostate cancer? Because it's a cold tumor, like this room. I don't know if anyone else feels this room is a little bit cold. It's a cold tumor. It's not as immunogenic as other tumors. It doesn't get as excited as other tumors. There is a immunosuppressive phenotype. There is a lot of tumor infiltrating lymphocytes which suppress the effector cells, and there is an upregulation of T regulatory cells and T helper 17 cells, and a less of CD8 T cytotoxic T cells. There are a few potential mechanisms explained, actually 3 of them mainly. One of them is myeloid-derived stromal cells, which is allowing the prostate cancer to progress. The second one is cancer-associated fibroblasts. This releases a cytokine, which also makes the cancer immunosuppressive. Lastly, it is tumor-associated macrophages. So for those of you who are familiar with this, there are two kinds. We don't want to clump all the TAMs into one. It can progress into M2, which is the immunosuppressive type, and there is the M1, which is the immunogenic ones. In colorectal cancers, there is data that there is a predominance of M1 tumor-associated macrophages, and that's why they're probably responding to immunotherapy. In the prostate cancer world, there is an overexpression of M2 tumor-associated macrophages. So these 3 major targets there's a lot of literature on this in Nature, Cell, and other basic science publications that this might be the ones which is making prostate cancer a cold, non-reactive tumor, just like Hannibal Lecter. It does not get excited as much. Radiation can alter tumor microenvironment. That's why in some cancers, radiation excites the tumor, creates a lot of neoantigens, and then you give them chemotherapy. There's a lot more cytotoxicity. There's a synergistic effect, but there are also studies which shows that radiation in prostate cancer can make these tumors more cold. Not a lot of data, but there are some animal studies which shows that as well. ADT, on the other hand, can improve the efficacy of immunotherapy. It reduces T cell tolerance so that they don't lose their efficacy in cytotoxicity. They also prime these patients, prime these T cells to react with prostate antigens. And the combination of ADT with immunotherapy is definitely synergistic because it continues to show some effect in most other trials. This is the immunotherapy current landscape. In August 2017, the first CAR-T was approved. 7 years prior to that, sipuleucel was approved. So prostate cancer world, they were way ahead, but then they lost track because they could not develop any further drugs after this. This was the first FDA-approved vaccine, and we know it is used for patients with very minimal symptoms and very limited metastasis. It's a vaccine, dendritic cell vaccine against prostatic acid phosphatase, which is expressed on prostate cancer cells. Pembrolizumab has a tissue-agnostic approval like dostarlimab for patients who have deficient MMR. This is a minority of patients of prostate cancer. And patients with high TMB or microsatellite instability, you can still use this. There is a subgroup of patients where this benefits. One of them is biallelic CDK12 mutations. I know Dr. Emmons mentioned that TP53, you have to know that there is a heterogeneous group, so it has to be biallelic. So these patients, by nature, have poor prognosis, but they are more immunogenic. They produce more neoantigens, so they respond to immunotherapy. So you have a marker which is a marker of poor prognosis, but fortunately they respond much higher than non-CDK12 mutated patients. High PD-L1 expression, they do respond. There also is a marker of aggressive disease in prostate cancer. So what are the overall benefits in improving overall survival in patients? Not a lot. There was a real-world study that was published in late 2019. I think this was an abstract ASCO GU 2019, which looked at 51 patients at Duke who received pembrolizumab. These were heavily pretreated patients, included patients who were treated with abiraterone and chemotherapy. Very modest response. 16% of them had a 50%, more than 50% confirmed PSA decline. There were a few patients who had a sustained greater than 90% PSA decline. I think there was 4 of them. 2 of them had one of them had deficient MMR, other one had a high tumor mutational burden, other one, 2 of them had a lipoprotein LDL receptor-related protein, which was also thought to be a marker that this might be something which responds to immunotherapy. But the duration of response, overall survival did not much significantly change. Very few patients had ongoing response. These are all the failed phase 3 trials. When I already mentioned Keynote 921, Keylink 010 was a trial which looked at pembrolizumab with olaparib, was a failure, was stopped. Prostvac is a prostate vaccine. It's a viral vector. This was studied with or without GM's colony-stimulating factors. Again, did not improve overall survival. There was a peptide vaccine which looked at HLA-A20 patients with HLA-A24. This is mostly seen in Asian population, mainly Japanese population, and this study was from Japan. HLA-A24 is also expressed in where I'm from in India and some parts of Asia. This phase 3 clinical trial was after some success in phase 1 and phase 2 clinical trials, which showed tumor activity, direction PSA, but the phase 3 clinical trial did not show any overall survival benefit, nothing new over there. The viable study was a dendritic cell vaccine, where the dendritic cell vaccine is on along the same principles as Sipuleucel, which is also based on dendritic cells. That also did not show any positive changes. There are some promising trials. CONTACT-2 seems to be discussed a lot in literature. This is a combination of cabozantinib and atezolizumab versus newer hormonal therapy. So this is a different arm. The earlier studies did show improved progression-free survival. Hopefully, subsequent study may or may not show overall survival benefit. Lutathera study is also promising, where you give one single dose of Lutathera and then you continue immunotherapy. The theory is that this Lutathera dose will turn the cold tumor environment maybe into more hot, more immunoreactive, and may increase overall survival. Initial data showed some safety, good safety signals and promising activity. We have to see if there are phase 3 trials which can prove that. Checkmate 650 trial, in some earlier studies, it did show some increased toxicity. That was because of the way they were dosing the Nivo and Ipi. We know the more Ipi we give, the more toxicity we have. Actually, any combination of Nivo and Ipi, it's always the ipilimumab which causes the toxicity. But there was some clinical activity in one of the cohorts with the Nivo Ipi. Looking forwards to see if there are any overall survival benefit. One study I have not mentioned here is a phase 3 study done by Dr. Fizazi, which looked at ipilimumab in patients who received radiotherapy. The initial study published in 2020 did not show any overall survival, but when they did a planned overall survival benefit, it did show that patients who received ipilimumab after radiotherapy did have overall survival, with 3, 5, and 7 years being almost double as the patients who did not receive ipilimumab. One of the reasons why I think in bony metastasis immunotherapy is more beneficial is because there is no much myeloid-derived stromal cells in the bone. There is more of myeloid-derived stromal cells in soft tissue metastasis in prostate cancer world. So that could potentially explain why in bony metastasis they probably respond to immunotherapy. There are a lot of emerging therapies. I know I have only 6.5 minutes. I can spend 1 hour talking about it. This is more in Dr. Radhakrishnan's world, where you're looking for new targets, which has not been previously tried. Bispecifics, there are a lot of bispecific being studies. 2 AMG products. One of them is 509, which is a luritamig. It is an anti-STEAP1, which is 6-transmembrane epithelial antigen protein. This is a marker on epithelial cells of prostate cancer cells. And the phase 1 initial studies did show some promising, and they might have phase 3 studies come up. There is a Regen 5678, which is again a PSMA CD28 bispecific. AMG also has another drug, pasotuximab, which is again a PSMA bispecific. There are also other bispecifics looking at PSA and PAP, which are all in the pipeline. There are a lot of vaccines, which also includes Prostvac-based studies and PSMA and PSA-based vaccines, all of them showing some preliminary data, like in other phase 1 studies of immunotherapy. What is also promising is CAR T. There is no solid organ clinical trial without including CAR T. Some new targets in addition to PSMA and PSA, which includes NKG2D and EPCAM. These are newer CAR Ts. People who do CAR Ts for a living probably know better than me. There are some promising activities. The concern is if this is going to add more toxicity without any clinical benefit, but that's the question we're going to answer in subsequent studies. Lifileucel was a drug which was approved last year for melanoma. This is a tumor infiltrating lymphocytes. There are not a lot of studies, but there are some promises that tumor infiltrating lymphocytes might be successful in prostate cancer. This is the same principle, take out some tissue, culture it, put it back, and with the hope that this would be cytotoxic. This is a cartoon, very complicated, put here intentionally to show how complicated the tumor microenvironment of prostate cancer cells is. We have numerous targets, of which we have only followed the path of PD-1 inhibitors. There are other targets which includes myeloid-derived stromal cells, T regulatory cells, other T cells, tumor-infiltrated lymphocytes, vaccines, CAR Ts, PSMA, PSA, any of these bispecifics. We need to explore more. We need to go back to the basic science lab, find out more potential targets, do some sequencing, preferably do next generation sequencing in every single patient. One of the things which was a highlight of Keynote 921 is that they did not have a molecular subgroup analysis. They did not find out if there were specific mutations that was more responsive to pembrolizumab docetaxel combination, like CDK12. If in future, if they do have that sequencing, maybe because this study was done between 2019 and 2021, they might not have a lot of tissue to sequence. Future studies, if they do, it would be important to have a subgroup analysis, not just the clinical characteristic, but a molecular subgroup analysis, so that we identify those patients who are more prone to respond to immunotherapy and not just the general population. Overall, what immunotherapy trials have shown us in prostate cancer is do not do this on an all-comer population. It doesn't work in an all-comer population. If you want to spend billions of dollars doing this again and again and again, you might see some modest responses, but I think it has to be a targeted, subgroup-defined population which is going to benefit from this. Next few slides. This is just a list of all those clinical trials, and some of them which already have been discontinued for lack of clinical activity or toxicity, showing what is the current immunotherapy landscape and future immunotherapy landscape in prostate cancer. We do have a clinical trial going on at the University of Kentucky. This is one arm would be, this is a phase 2 randomized trial. All patients would get radiation with immunotherapy, and the comparator arm would be with or without olaparib. Olaparib is a PARP inhibitor, causes DNA damage. This is increased cytotoxic efficacy. This is excite the cells that both radiation and immunotherapy is going to kill. The cells, we don't know. Clinical trial, hopefully this will be positive. We also have another clinical trial, radium-223, which with an experimental drug, it's M3814 plus avelumab. Avelumab is one of those newer PD-L1 inhibitor, same principle, and we'll see what it turns out to be. All right, here are the key takeaways. Immunotherapy, not yet prime time, maybe, maybe not. There are a lot of future promising treatments. These future promising treatments are based on advancing or knowing about the tumor microenvironment. Where exactly can we target? Do we need more than one target? How can we make these tumors hot, and how can we get them to respond very well to immunotherapy or the newer drugs? We need to look into more non-PD-1, PD-L1 targeting drugs. In defense of all the researchers who've looked into phase 2 and phase 3 clinical trials, these were all designed prior to knowing other targets. So most of the trials are from prior to 2020, including the Keynote 921, which most of the patients were recruited from 2019 to 2021. Things have changed a lot. There is something everyone knows that AI has been doing, which is identifying targets at a rapid pace. Dr. Radhakrishnan mentioned in his study also he used some AI model to predict some targets. That would be something which I would be looking forward to. If we can identify those subset of patients who respond very well to treatment and base your new drug development based on that. BITE and adaptive immunotherapy, as I mentioned, is promising. And hopefully in the next 3-4 years, we might have at least another FDA approval for immunotherapy in prostate cancer. And with that, I end my talk. Thank you.
Questions for Dr. Veedu?
Yeah.
For the ongoing radiation plus checkpoint inhibitor trial in prostate, what were the discussions like to select by PD-L1 or other factors to potentially hone in on that subgroup within prostate cancer?
For selection of inclusion criteria, all patients. Yeah, I know. I don't know if every single sender checks for PD-L1 expression in prostate cancer. One of the things in Keynote 921 was that at time of enrollment, only about 24 and 20%, 25% in the control arm and 20% in the placebo arm had PD-L1 expression. And then as the study progressed, they had more and more patients whose PD-L1 expression was presented. So maybe we're not checking PD-L1 expression enough in prostate cancers. I don't know if anyone has a different practice where they check PD-L1 on all prostate cancers. And I think we should, especially in the clinical trial setting, we should definitely do it.
Other questions?
Excellent overview. You took a topic that not much that you would say within immunotherapy within prostate cancer. I always remind people that Provenge was the original immunotherapy in solid tumor with an approval in 2010. And
the OG, yeah.
Yes, exactly. So, but obviously we haven't made a lot of leeway within prostate cancer since then as well too. But I think that similar comment to what Wade had made as well too, that I think that radioligands in combination with immune treatment, I think seem to be more of where I think the field is going to potentially go. Obviously with lutetium treatment, the castrate resistance setting being now approved earlier for folks that do not want to do any chemotherapy as well too, as of the FDA approval in February or so, or January. I think that that's where I think the field is moving as well too. And I think that there are trials that are looking at that already as well too, of combining, lutetium with Pembro, with nivolumab as well too, and seeing if we can make, like you said, exactly a cold tumor into a hot tumor as well too. And the thought is that maybe by introducing lutetium, we increase neoantigen presentation. That is why mechanisms like, pembrolizumab and nivolumab can work a little bit better as well too. What do you foresee, I guess, in the future in terms of radioligand treatments and things like that within prostate cancer as well too? Are we going to move beyond lutetium as well? There's other compounds like actinium, 225, others that are out there as well too. And how does that fit into immunotherapy as well?
Yeah, to the best of my knowledge, I don't think any of these newer radioligands has been studied with immunotherapy combination. I do think they do have a role, like in those patients who are not getting immunotherapy, the newer radioligands, and maybe a target beyond PSMA. I think it is the same principle. It is very promising that if we can get these tumors excited, then you can add maybe immunotherapy or olaparib or other drugs. As of now, it's small, very limited studies of non-Lutathera clinical trials. I don't remember seeing a lot of phase 1 trials with the non-Lutathera radioligands, but I do think there is a role for that. Yeah.
One last question.
Yeah.
And that is, prostate cancer is essentially part of being male. If you live long enough, you're going to get it. In autopsy studies, it's found in small amounts in virtually everybody.
Right.
So my question is, given that it's a cold thing, and it's a thing of older men, and it seems to be the natural destiny of prostate, is this really a failure of the immune system more than a problem of the cancer? In other words, is it the senescent immune system that's causing problems with allowing this prostate cancer to become a full-blown problem for the patient? and the reason why these immunotherapies are not working very well? And is it really more an issue of understanding senescent immunity in these older people that
Right.
will help to prevent and potentially treat the prostate cancers?
Absolutely. There is a lot of papers which say it is tumor evasion, sorry, not invasion, tumor evasion. That cells are becoming smarter and evading tumor immunity. So one thing which the T regulator cells does is that it kind of maintains that immunosuppressive environment. And why it does that, probably we need more translational and transcriptic studies to say what is the protein synthesis that is leading to these T cell regulation. One thing is, yes, it is a disease of older men, but when even though prostate cancer overall has a good prognosis, it does not apply to metastatic castration-resistant prostate cancers because the median overall survival is 30 months. So the tumor is still aggressive, but it's the tumor microenvironment which is evading the immune system. And we don't know what exactly. We do know there are some combination of MDSCs and CAFs and tumor-associated macrophages, interleukin-17, all of that. But what can be done to stop that or upregulate or downregulate that specific positive and negative marker, we don't know that yet. Did I answer that? Yep. That I think is definitely tumor evasion. That's the bottom line. Like, yep, it is. There's different ways and mechanisms, but it is somehow evading the body's immune system, and we need to find a way to stop that.
Thank you again, Dr.
All right. Thank you.